much, Dr. Grube. We are very glad to have you here for this brief interview for the Brazilian Society of Interventional Cardiology Congress. And this year, in 2018, we are really happy to celebrate the 10th year of the first TAVI in Brazil. The first transcatheter aortic valve replacement that was performed 10 years ago. So first of all, I would like to thank you in the name of all the Brazilian Society for your help over these years to train a lot of physicians, to help proctoring and mentoring a lot of us. And also, I want to ask you, what were the really difficulties? How was in the beginning of the TAVR to come here to Brazil with all anesthesiologists, echo, everybody from Germany, to do these first cases, and now we're not intubating the patient, we're not doing all those things. So please tell the Brazilian specialists, how was in the beginning of the TAVR discovery?
Yeah, Henrique, thank you very much. First of all, that you are giving me the opportunity to talk here at the Brazilian Society about this procedure. It has been a great success, and of course I'm very emotionally moved by the honor and the award that you gave me today in the name of the Brazilian Society. I've been very happy and very privileged to work here in Brazil with our friends and colleagues. And I remember very well how I started the journey. For me, it was actually a double journey. I started the first journey in Germany with the first cases, or in Europe, I should say. And then after we had some experience, with this procedure, I fell in love with this country, very simple. And I wanted to work here, I wanted to be here, and so I talked to the company and said, you have to provide the valves for me to enter this market. Obviously, at that time, Brazil or Latin America as a whole was not on the screen of these companies. They wanted to gain access into the European markets and then maybe US markets, but Latin America wasn't really on the screen. So it was a risk for them, and it was a particular risk for me because we were not that experienced yet. I had friends at Albert Einstein, as you well know. The team there asked me to come, and I was allowed to do this. Ethics committee approval we received, and it was a very, very emotional time because this case had to be well done with great success. And always when you do cases, as you know yourself, there's pressure. There's pressure, people are looking, and Brazilian society and Brazilian physicians didn't have much experience with all these things, nor did we. We just did the first 200 cases maybe, but it was kind of risky, but it was a lot of fun and eventually very successful. And that was the good thing when we started this journey. I tried to work here, and I did work here, and the journey began actually in those years with a great team at Albert Einstein. I brought my German friends, number one, to make me feel a little bit better, and to actually see that we secure the whole environment, which was new, obviously, to the hospital.
And now that we are, 10 years after the beginning of the procedure, we really have better devices, better technique. The physicians and the heart team are all well, organized for the procedure. We're moving for conscious sedation, avoiding pre-dilatation, and moving, of course, to lower risk patients. So we just gave a conference on the future of TAVR, and after, feeling so emotional in participating in all those advancements with the TAVR field, if you get from now within 5 to 10 years, what are your expectations with the TAVR field? For instance, do you think that within 5 to 10 years TAVR will be the #1 procedure instead of regular surgery, for instance?
obviously, and I will answer this question fairly easily, even though there's a prediction, but I believe that there's no question that now that we're moving into the lower risk patients, the risk situation is a little bit different from age. So sometimes people are confusing things when they talk about low risk and younger age. This is not the same, as you well know. So I have no doubt that moving into the lower risk patient group, TAVR will be equal, if not superior, to surgery. Obviously, all procedures that are less invasive with equal efficacy are superior to invasive methods. So that's quite clear. So I believe that we will be doing TAVR in those risk groups. Younger age is a little bit different. Younger age is different because I think we have to revisit some of our complications. Most of the complications in the initial phase with first generation valves are gone. But there are 2 or 3 things that we have to look into: pacemakers, stroke, and durability. Those questions have to be resolved. Younger age means, for the TAVR definition, below 70. It's different when you go maybe into an 85-year-old. The pacemaker is not a serious problem. If you go into a 60 or 50-year-old, it might be. So we have to revisit younger age and separate that from low risk. No question, this will move forward, and at the end of the day, this will be the treatment of choice.
So, Dr. Grube, thank you so much for your interview. And again, in the name of all the Brazilian Society of Cardiology and Intervention Cardiology, thank you so much for all your contribution to our country, for helping many doctors, to really get into the TAVR field and to learn, as you mentioned, and to advance. And for sure, it's a great privilege for us to have you here. Thank you so much.
Thank you very much. Very happy to be here and very proud to be back. Thank you.